Plus tarder, je vais céder la parole à notre facilitatrice aujourd'hui. Alors, notre facilitatrice, c'est celle qui animera un peu la discussion et pourra orienter certaines questions, est Dorothy Barthélémy. Dorothy Barthélémy est professeure agrégée en physiothérapie à l'École de réadaptation de l'Université de Montréal. Elle est bien sûr chercheuse au CRIR, et puis ici, elle est responsable du créneau mobilité à l'Institut universitaire chez nous. Sans plus tarder, Dorothy, à toi la parole.
Merci beaucoup, Frédéric, et bonjour à tous et à toutes. Merci de nous avoir rejoints pour cette conférence Interaction. Donc, moi, en fait, je vais présenter M. Franck et aussi animer la période de questions après la conférence ou l'échange qu'il va y avoir. Mais d'abord, une courte présentation de M. Franck, et I will do this in English. So, Mr. Han Franck is trained as an occupational therapist. He has obtained his Master in Science in 2010 and a PhD in 2020 at the University of Maastricht. He is now an occupational therapist and a clinical researcher at the Department of Brain Injury Rehabilitation of Adelante Rehabilitation Center. He is also the owner of the Frank Hanskill private practice and a lecturer and trainer at different instances such as the Dutch Paramedic Institute, the Center of Expertise in Rehabilitation and Audiology in Adelante Rehab Center, and is associated with the Dutch Rehabilitation Physician Association. His field of interests are clinical management of shoulder, arm, and hand rehabilitation in stroke and TBI, with a special interest in stroke survivors suffering from a moderately to severely impaired arm and hand. As such, he has several peer-reviewed publications, notably in Neurorehabilitation +1 and the International Journal of Stroke, just to name a few. So more specifically for today, his aim is to significantly improve arm-hand recovery using a novel approach that he developed, which is the CARAS program, which is short for the Concise Arm and Hand Rehabilitation Approach in Stroke. So then, Mr. Franck, it's my pleasure to welcome you at this talk at the IURDPM and to know more about the CARAS program. Thank you.
Thank you, Dorothy. Yeah, so the initial question for this conference was to make a sort of distinction from, because in certain regions in Canada and also in other countries, there was another program. It's running. It's called GRASP. I think for some of you, is it familiar? So the initial question was from your perspective, and could you tell us some differences between the GRASP program and the CARAS program, which is also running in almost a substantial part of the Netherlands in rehab centers and somewhere also abroad. And I say, well, I can do that, but it's a very difficult thing. I think I better talk about my program, and then we can make, or you can make the distinctions by yourself. So that's why this small conference is about. I will try to make it small, and I have to summarize it a bit. So sometimes things are, I think, a little bit too fast, but I hope I can review everything which I want to say in about half an hour. So I will share the screen now, and I hope that everything will become also clear for you that I'm starting up the PowerPoint now. Is it a visual for you? Yes, I see some head knocking. Okay, great. So about the program, well, to go from scratch on why I built the program, that's a bit too difficult to talk about it in half an hour, but it's built for clinicians, PTs and OTs, and also rehab physicians, just to have a practical but also an evidence-based framework, which gives insights about how you could train persons in stroke who have a moderate till severe arm and hand issue, and the mildly impaired persons, we take them also with them, but it's specially designed for people who are moderately and severely impaired, but they have the ability and also prognostics, the idea that they can go to a functional hand. So my introduction was already done by Dorothy, so I will skip this part. So the idea is, when we're working as clinicians, I mean, when I work as a clinician in a rehab, I also had the idea that I had a problem with a few things, that the one patient is not the other. So we also have talking about heterogeneous. There are people who have different levels of patterns of recovery, and the one is severely impaired and the other is mildly impaired, and no one is the same. So what also was an issue in my center was, okay, where is the patient involved? Because he is the main stakeholder of his issue, that he has to put in and using his affected arm and hand into practical situations, and not the therapist, because it's not the therapist's hand. So, and also a difficult thing was, if there are new things, new developments, in worldwide, new technologies, and you saw that there were also centers who were building up a program around that technology instead to look for, okay, what do we have as conventional therapy, and can we implement that without disturbing daily routines? So that was also something to consider. And the last but not least is that if you look into descriptions of treatment programs for persons with a moderately and severely arm and hand issue, so they are not able at that point of time to make nice functional grasp, but they can do that in future, then there are not very adequate descriptions or protocols or guidelines how you could do that. So looking to that, I had the idea about 10 years ago to stratify patients into different levels of dexterity, very severe, moderately and mildly impaired, but also using self-efficacy principles to overcome the idea that patients were dependent of the therapist. They had to work by themselves as much as possible, and to get also intrinsic motivated during the process, during the rehab, to put that hand as fast as possible into daily performance. So I also built it in a way that if there were new insights and new techniques, that you could put them very easily within a program without disturbing your daily routines, that you have to fit in a thing, that you have to plan and reschedule patients because it's something new into your rehab routines. And I want to have something which was well described, but not protocoled, so that therapists could also think by themselves, but that they get certain clear stepwise procedures and where most of the persons could fit in. So that's why I built the CARAS program about approximately 10 years ago, implemented it in the rehab center where I am still working. And if you can see it, it's very clear. It's in boxes. You have two parts. Part one is for people who are very severely impaired and they have no ability to use that arm and hand voluntarily into functional tasks. And then we have a part two, which is task-oriented. It's for persons who have initially no functional hand, but they will go to functional hand. And people, and that's program 3, for people who have mildly impaired arm and hand issues, and they can work through a functional performance program. So this is built as a sort of conventional therapy, because if you look into research, you always see that there is an experimental group, and they're talking about research and what they do in the experimental phase, and it's a lot of words is used for that. But conventional therapy is not something which is described very well, especially not in that moderately and severely impaired group. So this is rather built as a sort of conventional therapy as a base. And from that base, you can use this as a sort of stable base and framework to put experimental novelties in this program, to monitor them and also to do research to them. So looking in depth to the program and looking to program 1, that's for persons who don't have any activity in the hand. So that program is built up in a way that's group-wise. So you have rookies in the program who are already a bit experienced, a few weeks, and you have new patients coming in an open group, and all the patients are learning the new patients what to do. And of course, the therapist has to guide that and to make sure that everything goes well according to a social influence model. So the peer groups, they all have a very severely affected arm and hand. They learn each other how to know, okay, what's going on in my brain, why my arm and hand is not working. So they get insight and they get information and they talk about it by themselves because they are the people and they are the victims. They also learn to become super and pain-free. So they get some passive exercises. They learn to position in different circumstances, lying supine, rolling, everything. They also learn active exercises to see and to monitor if the arm and hand is perhaps revolving and is making progress. Then they also learn how to apply mobility aids like a mitt or a splint or something like that. And then afterwards, they have a test. So the person who's leaving the group always has to lead the group at that point of time and let's show what he has learned. So it's a sort of social cohesion in a few weeks. It's an open group, people are coming in and people going out, and they learn around these teams how to manage that very severely affected arm and hand. So we use some guides for that, and then they will they will stop after about 5 or 6 weeks. So the part 2 is the task-oriented training program. It's basically built for people who are very severely impaired, but they have some distal flexion in the wrist. So they have a very low Fugel-Meyer score and also a very low ARED score, about 4 points. Then you barely can anything do functionally. But they can start in this program because they have, in perspective and prognostically, they have a way that they can use that functional hand in a functional way as an assistive hand. And then we have, of course, the grasp program in a way that these people already have a functional grasp, and they already have also a higher Fugel-Meyer score or ARED score, and they can start already very functional and also distal in difficult functional tasks. So from a patient perspective, to go a little bit in depth in the task-oriented part of the program, it's always that they want, of course, they want to be independent, and they want to have, of course, skill performance in their arm and hand. Otherwise, you can't be independent as they should, as they want to be. But sometimes we make a step over it, and then we say, okay, but what they want is they want to have the self-perceived performance that they feel that they can be independent, that they feel and that they get motivated and encouraged that they really actually can use that arm and hand beyond the clinical situations. So the whole program is built in a way that people are getting motivated, and that in their behavior that they are motivated in a way that they're going to use their affected arm and hand as fast as possible beyond clinical situations. So of course they learn things in the therapist and in therapy situations, but in a way that when they're leaving the clinic after an hour or 2 hours, or when they're leaving the room where they had the training, they had the idea, okay, I have learned something very quick. It's all about quick wins. And of course, then they can also participate in the roles which they desire. So from a clinical perspective, as therapists, we also think about independency. And we have that heterogeneous population. And we also have the issue that we need for transparency, that if I'm seeing a patient, but I'm sick or I'm running out, then our therapist can take over and do more or less the same things, that there is a coherence between, in this case, between therapists and also between physicians. And also because there are lots of novel and effective innovations coming up and already implemented in the center, I want them to have them quick within the program, but if they're not working, I want to have them de-implemented as fast as possible without having any disturbances. So that's why also this program has built up in time blocks, which is very easy to replace and to put in technology and to get rid of it if it is not working in a proper way. So in general, I think we all know this small spot as a stroke. And in the program, we know all that if there is a severe stroke, then you have a problem in using your arm and hand. And it's also a problem that you don't have any skills to take some fruit or to take some veggies and to make a soup, and that you're not able to do at home and make your favorite soup, and that you can't be there what you want to do. And also in the training program, it's not about the function, the initial first dia. It's about everything, because if you can't do that, you of course have a function problem. You can't make a voluntary grasp, and then you have a performance problem because you can't use it to take veggies in your hand and to peel it, for instance. But you also have a problem on activity level, and you have a problem on participation level. And within the program, we're working on all those fields. On all those fields of the ICF, we have accents. So it's not only the function, it's not only skill performance, it's not only activity level, but through the program every day, when people are working, we deviate through these 4 areas of the ICF. And it works like this. It's very simple. We're starting here. This is a group 3 program at Monday morning, and they have a goal. The goal has to be attainable, of course, in 1 week. Otherwise, they can't work in it and they don't get motivated. They always check, okay, how does it work at this point? If you start with the goal, then they have the training program, which is built up in using a sort of analysis, using an analysis form. I will show it later on. Then afterwards, in about 30-40 minutes, we go back and to check the quality of the skills, what is gained, what is have been lost. And then they get homework assignments. Sometimes they get homework assignments during the week, but they always get homework assignments at Friday. So on participation level, if you have homework and you did a sort of, for instance, you were eating with knife and fork, and you're working through that the whole week, Monday, Wednesday, and Friday, 3 times 1 hour, then at Friday, if you gained some progressions in it, you have to take it at home, and then you start home using eating knife and fork, or at the ward if you're still as an inpatient in the clinic. And then afterwards, at Monday, you come back, start with another goal, but first you talk about how do you use your hand beyond the clinical situation. So at participation level. So here we go through all those levels of the ICF in a sort of step, a sort of line. And this little circle, starting with goal settings per week, 1 goal. It's very easy and very clear for patients. And of course, the goal setting is also in negotiation with the therapist, because they have to be attainable in 1 or 2 weeks. So there's always a link, working in the clinic with CARAS, there's always a link to the situations beyond the CARAS program, at home or at the ward. And they have to get back at Monday. Okay, what did you do with your affected arm and hand? What were your assignments for this weekend? And so we have a sort of closed loop system, a control system in which people can control themselves, okay, and also their peers. What are you doing actually with your arm and hand? So, Frederic, if you would play video 1. This is a woman at Monday morning in program 3 from CARAS. So she's mildly affected. And her idea was, and her goal was, to put off the blankets because it was very difficult for her to do that on the ward. She was still an inpatient. So you have to tell me when the video has stopped, Frederic, because I can't see that. But you see, she's hampering. Still running?
It is now running.
It's not running?
It is now running.
Okay, great. So you see she's hampering, and it goes not very fluent. So there are some coordination issues and some strength issues. Yes. So what we do is, before people are being admitted to the group and to CARAS, we always do a sort of analysis to see where is the main problem, why people are not functioning as they should be. Of course, they have a stroke, so they always have a strength problem, but we can differentiate very easily where the strength problem is. And then we also look in the model of, okay, are there other problems like coordination, and where in the coordination is the main issue? Is it dysmetry? Is it fluency? Is it one of the scaling principles? But which one is the most prominent one which hampers her in the functionality? And in her case, she also has a proprioception problem. So of course, I make it easy in this case because we are now on video and working each other. But people also have sometimes other problems, as we know, as we all experienced therapists in the neurology. So in her case, in this case, we saw, okay, here are the main issues, and then we differentiate where are the main issues in her case, and then we build up the program for her. So here we say, okay, for her, she has to learn implicitly because it fits the task and also her as person. Perceptual learning is very important for her because she has also a proprioception issue. And then we also have some ideas about how we give instructions, how we give feedback, and how we organize for her the therapy content. And then what we always do in patients also is that because they always have a shoulder at risk, we differentiate always when there is a stroke and they have the issues that the shoulder is always involved in one way or the other. And I think we all know that if we look into stroke patients, then the primary neurologic deficit in stroke are on the ventral part of the shoulder. So the secondary issues, not neural affected, are on the backside of the shoulder, more or less, because you have 17 muscles in the shoulder, and normally 7 or 8 are affected, and the rest is not working properly. So you can make very easy gains, quick wins, very fast in a few minutes, or 15 minutes or 20 minutes, that you can let a patient feel that they can make progressions by using not neurally affected components proximally. I will show you later on how that works. So we always do a sort of analysis of the shoulder by flaccid paresis, like this patient. You see always that the shoulder is a little bit depressed and also a little bit in retraction. In subtraction paresis, when they have more tension or more spasticity or hypertonic, you see normally that there is a protracted shoulder and also a depressed or sometimes elevated shoulder. But just for this case and this patient, to illustrate it, I think that would be enough. And then we do a sort of extra analysis based on the shoulder, from what is the issue on shoulder level, why she's not working. And then we build a workbook and where fits in everything that she needs. So this is her first week in 6 weeks of the CARAS program. Here are the basic exercises setting up attached to the task, which is pulling blankets. And then she also is going to rate her progressions during every session when she is in the program. So you get a sort of self-controlled loop that people have to rate themselves in progressions. And I, as a therapist, can see also if they make progressions. So in that case, it's self-controlled and works quite fine. Then we fill the workbook, which every patient has, with basic exercises and of course tailor-made exercises. And then you have a sort of fit, in this case, as an illustration. She starts always with the task. Then she goes to a few exercises which are most convenient for her, attached to the task and also her impairments. And then afterwards, she goes back to the task again to see what is the differences between the first time when you are performing the task and the second time in about 45, 50 minutes. So just as an idea, examples which are filled in the workbook, you could use some stretch exercises when it is needed, but you also can, of course, using scapulatorical exercises. It's, of course, very at function level, of course, I'm aware about that. And then here you have also an exercise of glenohumeral for shoulder. I think we're all familiar with this kind of exercises. And then after these kind of exercises, when they are tailor-made for the patient, you go back, of course, to the task and see and feel if there are progressions made. So I'm going to stop sharing. This is video 2, Frederick. So this is about after 45 minutes.
You all see it just fine?
It's a bit slow on my side, but I hope it's working quite fine in your situation.
Yeah, we see it well.
Yeah. So you see here, this is ended. Yeah. And I think you can also play video 3, Frederick, if you would do that. So this is at Friday. So she came 3 times for 1 hour, 1.5 hours to the CARAS program, program 3. And then we always do the task on the same way. And here she ends at Friday. And I think we all see that there's a little bit differentiation. She's using less strategies, less compensation strategies at the end of the week. And she also rated in a visual analog score at a 7. So she is pretty satisfied, and she can use this as a homework assignment back to the ward, but also back home. Okay, you're going to exercise that, and perhaps there are also some other tasks which are affiliated to this task, which you can use and which you can perform at home. So it's about quick wins, and we use that quick wins to get people motivated very fast in a few hours, in a few days. And then we use normally not neural affected components to start with, just to start with, because I think we all know that in 1 week you can build up strength. So the progressions which you see is all about the reducing the compensation strategies. So, but it asks a proper analysis to do so. So I go further and I share the screen again with you. Let me see. Here we are again. Yes. So besides the personal goals, which people are working on very easily in 6 weeks, 6 goals, we also use a sort of modules which are based on analogy learning. So it's about experience-based, but they are well known in about the youth, and it's a little bit more very easy. So they have their personal goals because they are as a pair together. They also have a sort of very easy things, activities to do, which are very recognizable for them from home-based experiences. And it's all based on analogy. So lunch during the flight, everybody knows how that feels. It's difficult, but if you're doing it together and it's a bit clumsy, it always is a little bit, nice to do so. So sometimes we have a small break and do this as a sort of extra repetitive task-oriented training idea. And we have lots of modules built in the CARAS program. These are just a few examples of them. So what's very important, and it's the basic idea about CARAS program 2 and 3, about the functional training program, part 2, is that they have to recognize their improvements during the task. and also afterwards. So mastering themselves is a very important principle of self-efficacy, which is also used in the program. We also use other self-efficacy principles, but it goes beyond the scope of this small presentation to talk about that. So going into that, removal blankets at Monday morning, she rates it on a visual analog scale from 0 till 10. 10 is as good as how it was before, a 5. And at Wednesday a 6, and at Friday she gives it an 8. And I thought it was a 7, but it's an 8. And so at that point of time, if she is using her homework assignments, and she gives herself assignments for at home, this one is fitting perfectly in this kind of assignments. So you have a sort of control loop within the patient, and also between the patient and the therapist, and also the therapist between the patient, and also the therapist and the therapist, because normally in a group of 2 or 4 patients, you have 2 therapists. And at Friday, if all the patient or patients are not making progressions, then something is going on. It's about the goal setting, perhaps it's too difficult, or perhaps we didn't give the proper exercises, or someone was sick. There's always a reason why people are not making progressions. So, of course, when I built the program several years ago, I also used a cohort study for approximately 100 persons to see if they really make progressions during the clinical phase, but especially afterwards. So I saw that at function level and also at skill performance level, they made significant improvements during the program, but also afterwards. So also at self-perceived performance, after 1 year follow-up, they were still making some progressions, and they also feel themselves, measured of course, that they had made progressions. And also I measured them with accelerometers at home from, okay, this is a clinical situation, we are measuring you, but what are you really doing at home with your affected arm and hand? And they also made significant improvements on actual arm and hand use at home based. So when we're looking just graphically to program 2, it's the middle program here. Then you see that on a Fugel-Meyer, the majority of the group was about 20 points. And after the program here, they had 2 times program 2, CARAS is 6 weeks, so 12 weeks of program. They make the significant improvement as a group. And I measured them 4 times in their home base, in their home situation, till a year afterwards, and they were still making improvements. And on the action research arm test, I think most of those tests are familiar with you. You see that the initial group at program 2, they have a median of 4 points on an AROT, which is not functional. And normally you get excluded in most training programs. But in CARAS program 2, you get fit in. And after the program, they had a median about 32 points. And measured them at home 4 times. So every 3 months, I measured them at home. They were still making progressions. So it is about 30 persons per group, 30 persons program 1, 30 in program 2, and 30 in program 3. And also on really using your arm at hand, you see that program 2 is the red dotted line. They start initially at the same level as persons who are very severely impaired and went admitted to the program 1, but they made progressions afterwards. And they also maintained those progressions using their affected arm and hand into daily situations far beyond clinical situations. So in the program, I use also very easy, low-cost technology things like very easy hand orthosis, arm support levels. I use a lot of functional electrostimulation, of course, only in patients who have initially some movement, but especially for persons who are motorily severely impaired, and they could use that extra efforts of the electrostimulation in the skill. And we use it also very functional. So it's all implemented in the analysis. And if they have a strength issue, for instance, the shoulder, then we use extra stimulation in the shoulder at that particular point to give the extra boost. And of course, they're not getting fast dependent. We also are getting rid of the fast segment at the end of the program. And of course, we also use more regular ideas like the body line and also shockwave to reduce spasticity in the program. And The idea is also in future, and I'm already talking about it with a Swiss company, to put robotics, more repetitive robotics, into the CARAS program, so that you have the proper analysis per patient, you measure it properly, and then you have the task-specific training. And in the workbook, there also are not only the simple exercises, and also not only the task-specific exercise, but also program X of robotic X and program Z of robotic I, that you can use the robotics integral within the program, that you can combine tasks, the conventional task-oriented training, with the high repetitive training which you could do with robotics. And then you go back to the task-specific training, and then you can work further on. So the CARAS program, in a way, has been built by me 10 years ago. There are several versions. In the Netherlands, there are 3 versions. One version for the specialized rehab centers who have a larger stroke ward, like Adelante, where I also work. Then I have a version in my practice, hand skills, which is only for single persons, and of course they work group-wise, but it's a simple version. And I have also a version for elderly care patients who are not that fit anymore, and they have some condition issues. But we have a consortium in the Netherlands, so we are attached to each other and connected to each other, and we see each other every year in Vivo, where we talk about issues in the program, or about novelties which we couldn't use in the program, and about we talk about also about how we're going further in future with the program. What do we have to change, because it's a living model, and everything is changing, also healthcare. So we also have to go further, and then we have to change the CARAS program over a little bit more towards what is necessary and what is asked by patients and also by organizations. And I also have a group, an app group, where we can feed each other when there's an issue with the patient. I know, okay, which patient for instance, in another region, okay, is a patient in CARAS program too. These are the variables, and then we can talk very easily with each other and to communicate very easily with each other how we can resolve the issue, especially in patients who are moderately affected. So I also have some, not really the same CARAS programs as they run in the Netherlands, but also in a few other countries abroad, there are CARAS programs. In Belgium, they're running very good. Italy, a little bit less. And in India and in Nepal, there are parts of the CARAS program running. And I give them also some lessons on distance to maintain and to make progressions. So this is the CARAS program, and I also work with companies together who are developing technologies, and which we can embed into, especially in the task-oriented training program. And yeah, and then there was the question about the differentiations between GRASP and CARAS, and that was very difficult for me to make, but I talked about it with Dorothea before this presentation. And if we look into content level, then we know that CARAS is built up, at least if it is not exactly very good communicated from my side, then my apologies. But it's about strength and function, improving hand function. And CARAS is not about proving hand function. Of course, you're making progress in hand function and also in strength, but it's all about using that affected arm and hand beyond clinical situations. So it's about improving self-perceived skill performances, and also actual arm and hand performance. And strength is, of course, a basic ingredient, but it's not the main ingredient. And another thing, which is other on organization level, is that GRASP can also be offered independently, CARAS also, but normally it's group-wise offered. And also when looking to the levels, then CARAS asks a no-risk extension. So CARAS, in CARAS, people can be assigned who are very low in function, lower as in GRASP. And it's not protocol-based. So CARAS is a guideline, can be adjusted to the needs of the organization where it's implemented. Of course, it had certain very clear steps which it has to follow, otherwise it isn't CARAS anymore, but it's certainly not protocol-based. I want therapists to think about it by themselves. I think those are the main differences between those both therapy paradigms. So that was my small presentation about, and sort of small introduction about CARAS. And thank you for listening. And perhaps there are some questions from your side.
Thank you very much, Mr. Frank. Thank you for this presentation.
You're welcome.
Bringing novel ways to discussing or addressing deficits in the hand and the arm. So I will open the floor for questions. If anybody has questions, they can either raise their hands and then we'll talk, or even write it directly in the chat. Well, in the meantime, while you're preparing your questions, maybe I have several questions, but maybe I can start with one question to you, Mr. Frank. So it was really interesting to see that in all the parts of the CARAS program, there's also social, so group work. Of course,
Exactly.
That's always interesting in an organizational level, well, at the level of the organization, the institution, because then it means that you can, address deficits or work with more participants at a time. But something I'm not sure I quite understand, because you still talked about some independent work. So how much one-on-one time do they have compared to group time? How do you organize this? Because they come 3 times a week for an hour. Is that correct? For an hour.
1.5 hour.
How do you organize this? Do they always have both a group and one-on-one, or one more than the other? How does it work?
Well, it is not one-on-one anymore. It's not face-to-face anymore. So people who are enter CARAS, they work always in a group, and they don't have one therapist to one patient to resolve arm and hand issues. And the group building has built for 2 reasons. One is indeed the social level, and that they can talk with each other and meet their peers and talk about issues. But more important is that they have to learn to use that affected arm and hand independently and by themselves. And the first step is to do that, of course, within the clinical situation, but in the eyes of the therapist. But if you are still, as a therapist, are still in face-to-face, then the patient is never encouraged to use that affected hand and to go to explore. But if you are one therapist on 2 or 3 patients, then the patient has to explore, because he has to fill that time in training. So as a therapist, you have to put the exercise in a way that most of the time patients can work by themselves, of course, within their limitations, and they are, of course, within, of course, it's limited, but they have to work by themselves as much as possible, already to learn in the program to do it by themselves.
Okay, I understand. So there is a therapist that is there to supervise, or maybe to place electrodes, or to place things, but and as well to reevaluate the objectives, I guess. But then the patient is really on his own with the exercise. So it's an exercise, maybe.
Exactly, an exercise, and then you go to the next. They all have their workbook. They have their exercises, and of course, sometimes you have hands-on, sometimes you have hands-off. Depends on the problem. And then you go to the next patient, and he has to do his exercise by his own. Then you go to patient 3. Then patient 2 is on his own. They have to learn to do it by themselves.
Yeah.
But
and how many? And just before I go to Marie-Claude Le Monde's question, so how many, in general, how many patients are seen by one or are supervised at a time by one therapist?
Yeah, in program 1, so the very affected patients, the very severely affected patient, is 1 therapist on 4, because they have to do it mainly by themselves. That works fine. In program 2, it's 1 therapist on 2 patients, because they are motorily impaired, so they are really needed to be supervised, and also sometimes hands-on. In program 3, it's 1 patient on 2 or sometimes on 3 patients, because they're mildly impaired. They can do more by themselves. So that's a little bit the deviation.
Thanks. So then I'll read the question of Madame Le Monde. Do you want to, Madame Le Monde, voulez-vous dire vous-même votre question? Or I can write it, I can say it for you if you want.
Yes, you can. I have a big accent in English, sorry.
Okay, no problem. I understand you well. So then, so Madame Le Monde Miss Le Monde is asking, during the first 0 to 12 weeks post-stroke, do you use FNM, so electrical stimulation with severely paralyzed limb, no movement, flaccid or spastic?
We use a lot of functional electrostimulation, but it always has to be, of course, a goal, like being more comfort, reducing spasticity always sometimes. We use it always, not always, sometimes, but we use it always when they have strength problems, but they have initial movements like extensors or flexors, which are working, but not working properly. Then we use it, I think, in 80% of the cases we use it. and it works quite fine.
Just a follow-up to her question. So you say you use it when they have a small movement. So then you don't use it when, for example, in group 1, program
No,
1,
no.
you don't use it at all.
No.
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 Is there a reason why you don't use it at all with patients who have no movement at all?
Well, if they don't have any initial movement, for instance, they don't have dorsal flexion and you don't have a functional hand because you are very severely affected, of course you can use electrostimulation, but then you have to be very keen in why you are using it. It's not for a functional purpose. Perhaps it's for becoming supple and pain-free. Perhaps it's becoming to reduce some pain, so you can use it, but then you have to be very keen why you are using it. Yeah. In program 2 and 3, it's more commonly because you always use it because they have initially movements. They have to get supported by the stimulation. Yeah.
Sometimes the stimulation also maybe could help with the sensory reafference, you know,
of course.
Then you can give the sensation of a movement and maybe that will propel them further.
Yeah. Of course.
Then I have another question from Philomena, JRH. So what are the exclusion criteria for participation in the CARAS program?
That's a very good question. When you are very cognitively very severely affected, or you have a very big neglect, or you have a very big attention problem, then of course it's very difficult to work group-wise. Then you have too much issues, too much, signals from other things why you can't be concentrated working. So those people are excluded. And of course, if people have inflammatory issues, like a shoulder issue which is not resolved, and they cannot train intensively, then it also is a pity to go to an intensive training program. So those two are exclusion criteria. Yeah.
Can I just jump back on this question? So the exclusion criteria. So for example, you talked about the shoulder. So we're talking about the pain, for example, pain. You know, when sometimes they have a painful shoulder.
Yeah, that's not an issue. Yeah, they can have a painful shoulder, but we have to know for sure what the pain caused. If you're not sure, then you cannot work through, because then you get more pain, because then you have, for instance, impingement or something like that. But if you are very familiar with the shoulder and you know where the pain is coming from, then people can train, but you have to diminish or to give the training in a way that is very comfortable for the patient. Yeah.
Thank you.
Yeah.
Is there any other questions? Well, then maybe I will ask another question as well. So the results you showed us, thank you for the results, by the way, because it was really interesting to see how it could change, not only during the therapy, but also right after, like 1 year after, when you really, when they're back in the community. So I have 2 questions for that. So the first one is for the people that increase, so you said 3 times a week, 1 hour, but then you said homeworks only at the end of the week. But I guess, you know, 3 times a week for 1 hour is more or less intensive. Do you suggest or encourage them to work as well outside of the supervised time? This is the first question. And the second question, it was about the group 1. There was not much change in group 1. The greatest advantage was group 2 and group 3. So was that to be expected? Were you surprised by that? What are your thoughts on this?
Yeah, starting with the second question, I was very glad because that admitting people to that very severely affected group was also a risk, because I'm admitting persons to a group which is not based on functional training. And of course, you always have people who are making progressions, but they're not walking the path of prognostics in the way as we think how it should be in stroke. So most of the patients, they were admitted to the right group, to group 1, because they didn't make any progressions. And of course, they also get exercise and also active exercises, but they didn't make any progressions at all. I think from the 28 or 30 patients, from the 30, I think 5 or 6 make progressions. And of course, they will get admitted to program 2. So they will shift to the next program. And program 2, of course, they're starting very low, so they're making progressions, and they also can enter very high into clinical measurements. So that's why they make large progressions, more as the mildly affected patients, of course. Yeah, and with respect to question 1, you have to remind me what the question exactly was.
It was just to say, because they said homework, so it's 3 times a week, 1 hour, and then you have homeworks afterwards. But do you encourage them as well during the week to
sometimes, because when they have a goal, all the goals where they work on, they have to be attainable and achievable in 1 or 2 weeks. But also very very something which is repetitive and is coming very near to the person itself. So normally there are ADL or ADL tasks from washing, groomery, every day. So they're working in the program 3 times, 1.5 hours per day. Most programs in the Netherlands do 1.5 hour, so it's about 4.5 hours a week. And when they're using on the goals, yeah, they get encouraged to work also beyond the program, but not specific. But they need to make progressions at home. So if they are making rates and they're making progressions, they have to use that affected harm at home or at the ward when they get back. But normally they get also encouraged to do that. So they make the assignments by themselves. Yeah.
That's good, thank you. And there's more questions, so I'm going to go straight to the questions. Some
Yes.
people, so 2 questions are similar. If we want to try the CARAS program, how do we get our hands on it? And there was a similar question from Gabrielle. So that was from Rachel. Gabrielle, is the CARAS program available in Quebec? Would we need training to administer the program?
Yeah. In the Netherlands and also abroad, it's so that normally for the basic CARAS, there is an implementation process on forehand. So if I'm giving a course, it's normally a 2-day course. Then giving the course is the 6th step of an implementation program. Because first I have to know, okay, what organization are you? Rehabilitation, elderly care. Then we talk about, okay, what are the specific needs, and does CARAS also fits within the organizational level? And then you have 5 steps, and then I will come over and give the course 2 or 3 days, and then there is a maintenance story afterwards. Yeah, but normally 2 or 3 days, then CARAS is running in a center without the maintenance. Yeah.
Okay,
yeah.
Thank you. So I guess that's really interesting here. There's another one question. What is the technology aid you use the most often? So robotic arm, this is from Marie-Claude again, a SIBO, glove, orthosis, bayonets, arm cycle, excite. Which kind of technological aid are you using?
Well, it's very difficult to say. I can't say that there is one particular technology which I always use, but in general, I always use those hand gloves, also those orthoses when people are not able to make a voluntary grasp. And I think from all the things, I think that electrostimulation I use the most to give sensory feedback or to give some extra strength. But sometimes also paired together with the glove or together with other things. Yeah, but there's not one particular thing which I'm using the most. What all the patients are getting, that is in general a way, is that they all get shoulder exercises. Mm-hmm. Yeah.
Yeah, shoulder seems to be the important component here to make sure that they have quick gains, I guess.
Exactly.
It's better innervated for both sides of the brain.
Yeah.
And so just to jump back on this question from Marie-Claude. So then the for example, if you go and you start the CARAS in another institute, so whichever they have, you can use. Is that what I understand? Whatever is there, whatever is available can be used and implemented. Is that correct?
You can use the basic materials in which you have already in your center. So you don't need anything very spectacular or exotic. No, otherwise it couldn't be implemented, also not in the Netherlands, because there are just a few centers in the Netherlands for using electrostimulation, but you just use to start in the basic CARAS with functional tools, functional things like we all have in our rehab centers. Yeah. And all the other technology are all adds-ons. Yeah.
Okay, that's great.
Yeah.
And then one question, almost I think the last one, because we are at the hour now, but this question goes back to the first 2 questions. So this question is from John. How to know who offers CARAS program in India? Addresses or facilities can be provided. So basically, I think the questions was, if you remember the other 2, how do they, if they want to implement this, or they want to check out and verify this, who can they contact? How can they verify it? How can they be done? Or if somebody wants to have it, how do they do that?
Yeah, that's a good question. In the Netherlands, to start simple, all the centers have ambassadors. So there are 2 therapists, an OT and a PT, who are very known with CARAS, and they are the key persons within one institute to go back if you have questions about the CARAS program and something's not running very well. Those 2 ambassadors, I see them every year in Vivo, somewhere in the center in the Netherlands. And I have also contact with them with the app, just WhatsApp, very simple. So that's a very easy system, because in the Netherlands we have it's small, so everything is reachable and you have a good communication network. So in India, it's complicated more. What we do there is that I also have 2 ambassadors, and they are directly contacting to me. So every month, it's voluntary work. So every month at Saturday, I have about half an hour, also using Zoom or Teams to talk them through a few issues, if possible. But sometimes it goes well for a few months, and then they get back to me if, okay, you want to talk a few things through. Can also be on content level with patients and talking about the CARAS program. So that's how it works. Yeah. You're welcome.
So I guess then if people want more information, because that's what I kind of feel from those questions, Frédéric or Mr. Frank, I mean, how should it be done? Frédéric, I think? Or?
Si vous avez un intérêt pour l'approche CARAS qui a fait l'objet des discussions aujourd'hui, si vous travaillez dans l'écosystème du CRIR, donc dans l'un des centres de réadaptation de la région montréalaise, à l'hôpital juif de réadaptation, au Centre-Ouest-de-l'Île-de-Montréal, du CISSS du Centre-Ouest ou ici au CISSS du Centre-Sud, n'hésitez pas à interpeller mes collègues coordonnateurs de recherche clinique ou moi-même, et puis nous pourrons saisir là, votre questionnement, votre demande, vos propositions et les orienter vers des chercheuses et chercheurs du CRIR. Donc, mes collègues, bien sûr, sont Philomena Pietrangelo à l'hôpital juif de réadaptation et puis Lucas Gomez-Souza qui travaille avec Chantal Robillard du côté du CISSS du Centre-Ouest. Si vous travaillez à l'extérieur de l'écosystème du CRIR, ben, vous pouvez faire la même chose. Vous pouvez nous interpeller et puis même si on se connaît moins et nous avons moins l'occasion de travailler ensemble, ben, il nous fera plaisir d'accueillir vos questionnements, interrogations et propositions et puis de voir comment on peut essayer de travailler ensemble. C'était tout l'objectif de la rencontre d'aujourd'hui, d'abord de prendre contact et puis de voir ce qui se manifestera. Est-ce que ça répond à la question que tu te posais, Dorothy?
Je pense que oui. I think that answers most the questions. So at least they know who to contact. I mean, of course, Han Frank has also a lot of papers. You can also look at them and see them.
Yeah.
But the offer from Frédéric is really good. I don't know if that's correct.
You may also contact Han Frank directly. As I've pointed out earlier in the presentation, the PowerPoint presentation will be shared.
Yeah.
I'll continue in French. Donc, les coordonnées de Han Frank sont à la toute fin du PDF qui vous sera acheminé. J'en profite pour signaler que vous recevrez un formulaire d'appréciation de l'activité d'aujourd'hui. Je vous invite à la remplir. Ça prend quelques instants à peine. Et puis, à l'IURDPM, chez nous, ça nous aide à concevoir des activités qui sont pertinentes pour les milieux cliniques que nous souhaitons servir. Et pour le milieu de la recherche, bien sûr, du CRIR et au-delà. Alors, so you will have a way to contact Han Frank directly.
Yeah.
I think our time is up.
Yeah. Okay, just one thing. In the PowerPoint, I also make links to the articles. So you see also and how to do article, how CARAS is built up. It's also in the PowerPoint available. Yeah, and it's all free download on internet. So there's nothing where you have to pay for.
Excellent.
Okay.
That's really good. Well, thank you very much.